Hello, lovely people. It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my Neuroanatomy playlist. In previous videos, we talked about the first cranial nerve, which is the olfactory nerve, the second, which is the optic nerve, the third cranial nerve, or the oculomotor. The fourth is the trochlear, because it's related to the trochlea. Fifth is the trigeminal nerve for sensation of my face and motor to the muscles of mastication. Then we have cranial nerve number 6, the abducens nerve. Why do we call it abducens? Because it abducts. Abducts what? Abducts my eye, meaning it will make my eye look laterally. I look towards my temple, not towards my nose, because the abducens nerve supplies the lateral rectus muscle. Today we shall talk about the abducens nerve and the deficit that I will suffer if I injure my abducens nerve. So click the like button, click the subscribe button, and let's get started. This video is part of my anatomy playlist, but if you just want neuroanatomy, I have a separate playlist for that as well. Quick review. The olfactory nerve is a special sensory afferent nerve. It's a sensory nerve for what kind of sensation? Olfaction or smell. Smell is the only sensation that does not relay in the thalamus. Then we have the optic nerve, also a special sensory afferent or somatic sensory afferent. What kind of sensation this time? Vision. Does vision relay in the thalamus? Yes, it's called the lateral geniculate body, which is part of the metathalamus, which is part of the thalamus. Then we have oculomotor, which is motor, not sensory. What kind of motor? Is it somatic motor or autonomic motor? Both. It is general somatic efferent and general visceral efferent. What does the oculomotor nerve do? It supplies all of the extraocular muscles except two. One of the two exceptions is the superior oblique, which is supplied by the trochlear nerve. So the trochlear nerve is somatic efferent or general somatic efferent. So the superior oblique muscle is one of the exceptions that is not supplied by the oculomotor. What was the other exception? It's the lateral rectus muscle, which is supplied by today's nerve, the abducens, which abducts. The trigeminal nerve is sensory for my face and motor through V3 only to the muscles of mastication and for other muscles. So the mandibular nerve supplies 8 muscles in total. What are the 8 muscles supplied by the trigeminal nerve? Please comment below. If you want to download these doozy, colorful, handwritten notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. Remember, here is my brain. Draw the line in the sand. In embryology, this is called the sulcus limitans. In the adult brain, this is near the central sulcus. In front is usually motor, behind is usually sensory. If I want to see something, vision is a sensation. It's one of the special senses. Look at the center for vision. Oh, it's behind the line because it's sensory. But let me try to move my eye. The frontal eye field is motor. It's in front of the line. How do I move my eyeball? You can use the oculomotor nerve, trochlear nerve, or abducens nerve. Who gives them orders? The frontal eye field. The same applies for the spinal cord. You draw the line in the sand. This is the previous sulcus limitans. In front is mostly motor, behind is mostly sensory. CNS includes the brain and spinal cord only. How about the cranial nerves and the spinal nerves? They are the peripheral nervous system. So today's nerve, the abducens nerve, is motor only. It's a cranial nerve, therefore it is peripheral nervous system. What is the structural unit of the nervous system? The neuron. But what's the functional unit? The reflex arc. Look at my neuron. I have a cell body or soma, and I have the axon. A collection of somas in the CNS is a nucleus. A collection of somas in the PNS is a ganglion. A collection of axons in the CNS is a tract. A collection of axons in the peripheral nervous system is a nerve. So today I'm telling you about the abducens nerve. The abducens nerve starts with an abducens nucleus in the pons. And then we have the abducens nerve as it exits the brain. When it was in the brain and a collection of somas, we called it a nucleus. The nucleus of the abducens nerve, or simply abducens nucleus. As I exit the brain and move forwards, now I'm outside of the CNS. So a collection of axons in the peripheral nervous system is the abducens nerve. Abducens nucleus, abducens nerve. Cranial nerves 1 and 2 come out of the forebrain. How about 3 and 4 connected to the midbrain? 5, 6, 7, and 8 are connected to the pons. 9, 10, 11, 12 to the medulla. Today we're talking about the abducens nerve, or the 6th cranial nerve, so it comes out of the pons. Where did the pons come from, embryologically speaking? From the metencephalon, which came from the rhombencephalon, which reminds me of the rhomboid shape of the 4th ventricle. Is the abducens nerve somatic only, autonomic only, or both? The answer, it is somatic only. Is it somatic motor or somatic sensory? It is somatic motor, and motor is efferent, so we call it somatic efferent or general somatic efferent. Does the abducens nerve has any autonomic fibers in it? No. The only cranial nerves that have autonomic, i.e. parasympathetic fibers in them are oculomotor, facial, glossopharyngeal, and this is not a 1, this is a 10. Vagus, baby. Since the abducens is purely motor and not motor and sensory, not motor and autonomic, it's just purely motor, it's gonna leave the brainstem straight ahead, forwards, and more medially, not laterally like these. Here are the extraocular muscles. This is medial, this is lateral. Which muscle is supplied by the abducens nerve? Only the lateral rectus muscle, which pulls my eyeball laterally, i.e. abducts. Abducts, abducens. Quick review, olfactory nerve started here as bipolar cells between the mucosal cells and the roof of my nose. Then after this, I go to the mitral cell in the olfactory bulb. After the bulb, I go to the tract, then the telencephalon. So it is sensory organ, nerve fibers, bulb, tract, forebrain. Similarly, the optic nerve starts at the sensory organ. These are the ganglion cells of the retina. Then I have a nerve, optic nerve. I have a bulb, optic chiasm. I have a tract, optic tract. I have a part of the forebrain, diencephalon. Oculomotor is motor, so we start in the brain and go outwards. The oculomotor left the midbrain after taking fibers from the oculomotor nucleus plus the Edinger-Westphal nucleus. Then we are here in the lateral wall of the cavernous sinus. We enter the orbit through the superior orbital fissure and through the tendinous ring. We divide into superior division and inferior division to supply the extraocular muscles and the levator palpebri superioris. Yes, we do have some parasympathetic fibers from the Edinger-Westphal nucleus. The postganglionic fibers here are the short ciliary nerves. We also borrow some sympathetic fibers from the sympathetic plexus that surrounds the internal carotid artery and the ophthalmic artery to supply the superior tarsal muscle, which is part of the levator palpebri superioris. Then cranial nerve 4 is the trochlea. Remember that cranial nerve 1 and 2 go to the forebrain. 3 and 4, midbrain, baby. I start in the midbrain at the trochlear nucleus, very close to the medial longitudinal fasciculus. Then it's the only nerve that goes through the back of the brain, not through the front. Remember, trochlear, tail, and trochlear tectum of midbrain. I'm related to the tectum. I go from behind. Then I turn around and go front. Forwards through the lateral wall of the cavernous sinus. Yet again, I am just below the oculomotor nerve inside the lateral wall of the cavernous sinus. Then I will enter the orbit through the superior orbital fissure, but outside the common tendinous ring. And I will supply one muscle only, which is the superior oblique muscle. The trigeminal nerve was the topic of the last video. It was crazy. It started from 4 different nuclei in the brainstem. Then we had the trigeminal ganglion, which is related to the superior petrosal sinus and the internal carotid artery. Then we have V1, V2, and V3, ophthalmic, maxillary, and mandibular. All of them have sensory functions. Mandibular is special because it has sensory functions and motor functions. Only V1 and V2 will enter into the cavernous sinus lateral wall. So in the lateral wall of the cavernous sinus, we have the oculomotor nerve, we have the trochlear nerve, and we have V1 and V2 of the trigeminal nerve. How about V3? It did not go to the cavernous sinus. Instead, it exited through the foramen ovale. Ophthalmic, what did you do? I gave you 3 terminal branches. And since I am the smallest nerve, I was embarrassed. So I do not wish to be in the spotlight. So I said, leave me the French toast alone. Lacrimal branch, frontal nerve, and nasociliary nerve are the three terminal branches of the ophthalmic nerve. Leave me the French toast alone. Don't forget that the lacrimal nerve is lateral, which means that the nasociliary will be medial. Then how about you, maxillary? I am for the maxilla. I will supply sensation for the upper jaw. But who's going to take care of the lower jaw then? Mandibular nerve. It will take care of the lower jaw. Thank you, lingual nerve and inferior alveolar nerve. And I will also have motor fibers to supply 8 muscles. 4 muscles of mastication and 4 muscles of no mastication. The 4 muscles of mastication are temporalis, masseter, medial pterygoid, lateral pterygoid. The 4 muscles of no mastications are 2 tensors and 2 others. The 2 tensors are tensor palati and tensor tympani, and the 2 others are mylohyoid and the anterior belly of the digastric muscle. But who supplies the posterior belly of the digastric muscle? Please comment below. Now let's talk about the abducens nerve. As always, bring a pen and paper and let's draw this together. Remember, cranial nerve 1 and 2 for brain, 3 and 4 midbrain, 5, 6, 7, 8 pons. So this is cranial nerve 6, so I gotta start at the pons. Here's the lovely pons, amazing. And then the abducens nerve starts at the abducens nucleus in the pons, and then it leaves anteriorly because it's purely motor. It is very close to the midline. And then what? I will have a very long life, a very long course inside the cerebrospinal fluid, i.e. in the subarachnoid space. Then I will pierce the dura mater like the champ, and I will enter into the cavernous sinus. Oh, you will go to the lateral wall of the cavernous sinus like the rest of them. Nuh-uh, I will go to the cavity of the cavernous sinus. Oh, you are different. And if you are in the cavity, you're very close to a very famous artery known as the internal carotid artery. Beautiful. Then what? As an abducens nerve, I will try to enter the orbit. How do you enter the orbit? Through the famous superior orbital fissure. Will you enter into the tendinous ring as well? Yes, indeed. I will also enter through the tendinous ring. Now I'm in the orbit. I will supply only one muscle, which is the lateral rectus, to abduct your eyeball. Abduct, hence abducens nerve. This is a motor function, and it's somatic motor, so they call me general somatic efferent or simply somatic efferent. This was cranial nerve number 6, so it starts from nucleus of cranial nerve number 6 or the abducens nucleus. Now let me tell you something about the facial nerve. The facial nerve nucleus, here's the nucleus for number 7, did something weird. It rotated around cranial nerve 6 nucleus and then the facial nerve exited the chat. Let's review. Here is my abducens nerve, somatic motor, somatic efferent, starting at the abducens motor nucleus in the pons, cranial pons or caudal pons, caudal pons. It exits at the pontomedullary junction. When I was inside the pons, the facial nerve did something weird. It started from the nucleus of facial nerve and then it danced around me like this. While dancing like this, it made an elevation at the back of the pons. This elevation was caused by the facial nerve, so they call it the facial colliculus. Not to be confused with your superior colliculus in the midbrain and the inferior colliculus, also in the midbrain. Back to the abducens nerve, I will leave my nucleus straight forward like this, very close to the midline because I am purely motor. And I am related to the medial longitudinal fasciculus, which is destroyed in multiple sclerosis. As I exit the pons, I have a very long course in the cerebrospinal fluid in the subarachnoid space. And that's why patients who suffer from intracranial hypertension, i.e. patients who have increased CSF pressure, will damage which nerve the most? Abducens nerve. So let's say I have trauma or hemorrhagic stroke due to rupture of a berry aneurysm. Or if I have intracerebral hemorrhage, tons of pressure inside. Or maybe I have idiopathic intracranial hypertension, formerly known as pseudotumor cerebri. Why pseudotumor? Because there is not an actual tumor in my brain, even though my intracranial pressure is elevated. Regardless of the cause, if I have increased intracranial pressure, the pressure of the CSF will go up and it will press on the poor abducens nerve, leading to abducens nerve palsy, which will make me unable to move my lateral rectus muscle, so my eye will not look laterally. Instead, my eye will deviate medially. Hashtag medial strabismus or medial squint. That's why many patients with idiopathic intracranial hypertension have medial strabismus, which causes diplopia or double vision. See, medicine makes so much sense once you understand what the flip you're talking about. Then after being in the CSF for so long, I pierce the dura like a champ. I enter to the cavity of the cavernous sinus and not in the lateral dural wall. Inside the cavernous sinus, I am closely related to the internal carotid artery. After this, I enter to the orbit via the superior orbital fissure and then pass through the tendinous ring, then supply the lateral rectus to abduct the eye, hence abducens. Let's take it to the clinic. We'll talk about abducens nerve palsy and we'll also review cavernous sinus thrombosis quickly. Remember oculomotor palsy? Yeah, I was down and out. I had blown pupil and droopy eyelid, which of course causes diplopia. How about the trochlear nerve palsy? The trochlear supply the superior oblique, which depresses the eyeball. If I cannot depress my eyeball will sneak upwards instead. Also, the superior oblique used to slightly abduct the eyeball or move it laterally. If I cannot move it laterally, it will swing medially. And of course, this can lead to double vision. So if the oculomotor palsy is down and out, the trochlear nerve palsy is up and in. If I'm looking up all the time, I cannot look down. It will be very difficult for me to walk downstairs. How about the abducens palsy? Well, imagine that I injured my right abducens nerve, so the right eye will suffer. This poor right eye cannot abduct. It cannot look laterally, so it will look medially instead, which causes medial strabismus, which leads to double vision or diplopia. Diplo means double, opia means vision. Next disease, cavernous sinus thrombosis. Remember the infamous dangerous triangle of the face. Let's suppose that you punched me in the face in the dangerous triangle. Injury can lead to infection, and the infection in this dangerous area can spread through some veins into the cavernous sinus, leading to cavernous sinus syndrome or cavernous sinus thrombosis. Remember that the cavernous sinus had what? Oh, it had the abducens in its cavity. It also had oculomotor in the lateral wall, followed by trochlear in the lateral wall, followed by V1 and V2 of the trigeminal in the lateral wall. All of these lovely nerves are related to moving my eye, baby, so I get what? I get double vision. After the punch, when I develop cavernous sinus syndrome, I can get periorbital edema, headache, photophobia, orbital swelling, proptosis, chemosis, and neurological symptoms. Remember that cranial nerve 3, cranial nerve 6 are motor nerves, so without them I get diplopia. Don't forget that the third cranial nerve also had parasympathetic autonomic nervous system fibers, so without it I get mydriasis. Third cranial nerve supplied the levator palpebri superioris. Without it I get droopy eyelid or ptosis. Related to the famous cavernous sinus, we also have V1 and V2. If I damage my V1, I get loss of sensation in the upper part of the face. If I damage V2, I get loss of sensation around the upper jaw. Remember that V1 is responsible for sensation from the cornea. If I cannot feel the cornea, I will not perform the cornea reflex. So I get what? Neurokeratitis. Inflammation of the cornea due to a neurological problem. From the punch, from the increased intracranial pressure, I get papilledema, retinal hemorrhage. And even though I started with one cavernous sinus involved, it can spread to the other cavernous sinus. Here is a quiz for you. What's the name of the nucleus in the brainstem that receives taste sensation from the tongue? Let me know your answer in the comments. You'll find the answer key in the next video where we'll talk about the facial nerve. The spread of infection to the cavernous sinus may warrant the administration of antibiotics. You can learn about antibacterials, antivirals, antifungals, and antiparasitic medications by downloading my antibiotics course at medicosisperfectionalis.com. It comes with videos, cases, questions, and a mind map. To learn about how your kidney functions, I have a renal physiology course for you. It will teach you about the GFR, renal clearance, the function of the proximal tubule, the loop of Henle, the distal tubule, titratable acidity, etc. If you want to learn about ophthalmological surgery, trauma surgery, orthopedic surgery, the types of shock, etc., download my surgery high yields course at medicosisperfectionalis.com. To learn about the differences between ischemic stroke and hemorrhagic stroke, to learn about angina and myocardial infarction, to learn about arrhythmias and ARDS, download my emergency medicine high yields course at medicosisperfectionalis.com. There are more than 300 premium videos on this channel, available only to those who click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.